And thanks everyone for joining. I really appreciate everybody being here. We're going to take just a few minutes and go over some interesting information about COVID-19 and SARS-CoV-2, and kind of bring you up to date a little bit about what's going on with the virus and the pandemic, etc. So this won't take too long, and if anybody has any questions, we can go over those at the end. But I wanted to start by making a differentiation between the disease and the virus. So the disease is called COVID-19, okay, which stands for Coronavirus Disease 2019. So COVID-19 is the name of the disease that the virus causes. The virus itself is called SARS-CoV-2, which stands for Severe Acute Respiratory Syndrome Coronavirus 2. So again, just a difference between what we call the disease and what we call the virus. Now, a little bit about transmission of this SARS-CoV-2 virus. It's spread through the air by close personal contact. It can also be spread by shaking hands, or once you touch something that's contaminated with the virus and then you touch your nose, your mouth, or your eyes before you wash your hands. But by far and away, the main way that this virus is transmitted is through the air, by something that we call droplet transmission or airborne transmission. Now, as you can see in the picture, when we exhale or sing or talk or yell, whatever the case may be, we will spread droplets out of our mouths and out of our noses. Now, these droplets can be of different sizes, as you can see in the picture. The real heavy ones, the big ones, are heavier, and they will float to the bottom and settle down on the ground pretty quickly. But as you can see, there's really, really small ones out there too, and it's those very small particles that can stay airborne. And these tiny particles will travel a lot further distance than the larger ones, which will drop to the ground. So as you can see in the picture on the right-hand side, these small droplets can be less than 5 microns, which is teeny tiny. You can see the picture of the droplet that's about 5 microns, and compare it to the size of a human hair in the picture there for you. So you can appreciate how small these tiny particles that contain the viruses are. So again, this is why we have the mitigation procedure of staying 6 feet away from each other during this pandemic. It's felt that these very small particles that are less than 5 microns, if you stand 6 feet apart, you should be protected from getting those smaller particles as well. Now, we know we talked about transmission and how the virus can be transmitted. It can be transmitted when you sneeze and you're infected with the virus, or if you cough, if you laugh, if you scream, if you sing. Simply by talking and breathing, we can spread this virus as well. So the best risk we can hope for until we get vaccine out to everybody is that even as well as the sick people wearing a mask, or people that are infected that may not actually have symptoms of disease wearing a mask, and every healthy person wearing a mask too. This will bring us the lowest risk possible of transmitting the virus, as everybody is wearing a mask. Now, medium risk is when one person is wearing a mask but the other person is not. You have some protection in this case, but not the best protection. And then, of course, high risk is when we know that people are not wearing masks and not keeping social distance. So again, what we want to do right now, in what we're going through right now with the pandemic in the United States and elsewhere in the world as well, is to do the lowest risk we can. And combining the last slide with this one, everybody wear a mask and everybody social distance. So I want to go over a little bit of difference between influenza virus and the SARS-CoV-2 virus, and point out to you in the next several slides why COVID-19 is not the flu. And the first thing we want to look at is infectivity. Now, there's a value called R0. That's the R with the little subscript 0. It's called R0. That's the basic reproduction number. And this basically says if one person is infected with the virus, how many other people will this person transmit that virus to? Okay. So with our seasonal influenza, the R0 is about 1.3. which means every infected individual will transmit that virus, the virus that they have, to on average, 1.3 other people. Now, if you contrast that to COVID-19 and the SARS-CoV-2 virus, the R0 is 2.25, or somewhere between 2 and 3, which means everybody that's infected with the SARS-CoV-2 virus will transmit their virus to at least 2 or 2.5 other people. So if we look at that after 10 rounds of exposure, we look at influenza with its R0 of 1.3. So one person will infect 1.3 other people. After 10 rounds of that infection cycle going on, you will see that with seasonal influenza, about 56 people will be sick. They would have gotten that influenza transmitted to them, starting from that original individual. Now, if we compare that to what happens with COVID-19, with those same 10 rounds of exposure based on the R0, rather than 56 people being sick, you'll have over 2,000 people that have now been infected with the virus. So again, big difference between influenza and COVID-19, just based on the transmissibility and infectivity of the virus. Another reason, or another difference, I should say, between influenza and SARS-CoV-2 is the incubation period. Now, the incubation period is defined as the time when you become first infected with the virus until you show your first signs and symptoms of being infected with the virus. With influenza, that's a range of 1 to 4 days with an average of 2 days. So from the time you're infected with the virus until the time you show your first symptoms is on average 2 days with influenza. With the SARS-CoV-2 virus, the range is much larger, 2 to 14 days with an average of 5 days. Again, that means from the time you're exposed to the virus until you get your first signs and symptoms of actually having an illness with the virus is an average of 5 days. Now, another thing to remember is that influenza patients are most infectious when they start their first signs and symptoms. So when the person with influenza first start getting their sore throat or their runny nose or their coughing or sneezing, that's when they're most infectious. That's different with COVID-19 patients, because COVID-19 patients can start shedding the virus and spreading the virus up to 48 hours before their symptoms start. So with an average of 5 days incubation period, day 3 and day 4 of your incubation period, when you do not have any signs or symptoms of disease, you will be spreading that virus to other people. So who's at risk for getting SARS-CoV-2? Well, everybody's at risk, obviously, for getting the infection, but the risk for severe disease will change depending on the population you're talking about. When we talk about age of patients, obviously people that are in their 50s have a higher risk for more severe illness than people that are younger. People in their 60s and 70s are at higher risk for severe illness than people that are younger in their 50s, etc. And the highest risk for severe disease is among, based on age, is in the patient population that is 85 years or older. Now, we've been talking about at risk for severe illness. What do we mean by severe illness? We don't mean, a headache, a slight fever, and a sore throat that go away in a couple of days, which can happen. That's a mild infection for most people. But severe illness is defined as hospitalization, with or without admission to the ICU, the need for mechanical ventilation, or death of the patient. So again, that's how we characterize severe illness. There are also, besides age, there's some underlying medical conditions that also put people at increased risk for severe illness with COVID-19, and they're listed on the slide here for you. People currently with cancer, chronic kidney disease, chronic obstructive pulmonary disease, Down syndrome, a variety of different heart conditions. If someone has had a solid organ transplant and they're in an immunocompromised state, as well as obesity, pregnancy, sickle cell disease, smoking, and type 2 diabetes. This is a list of people that have these underlying medical conditions that are an increased risk for severe illness from this virus. Now, there's been a lot being said about testing, and you know COPAN's very involved with the collection systems for testing for respiratory viruses, and certainly that includes SARS-CoV-2. So certainly people who have symptoms of COVID-19 infection should be tested. People who have had close contact with someone that has been confirmed to have COVID-19 should also be infected, or should also be tested. And close contact is defined as being within 6 feet of that individual for a total of 15 minutes or more. And that does not have to be 15 minutes in one block. It could be 5 minutes in the morning, 5 minutes around noon, and 5 minutes later on in the afternoon. So for a total of 15 minutes or more that you're around that person in a day, that's defined as close contact. And then certainly people who have been asked by their physician or their the state or public health department to be tested, they may be doing some contact tracing and understand that you've been exposed, even if you don't realize you've been exposed. Now, not everybody needs to be tested, obviously, but these are the people who should get tested. But if you do get tested, until you have the results of your test, you should self-quarantine or isolate at home pending the results, and then follow the instructions either from your healthcare worker or by the public health professional. Now, if you do get a test and you test positive for COVID-19, you should stay home, except to get additional medical care if you need it. But most people, again, will not have severe illness. Most people have mild COVID-19 illnesses and can recover at home. It is recommended that you separate or isolate yourself from others for at least 7 days. And if you have a negative test at 7 days, then you can come out of self-quarantine. If you don't have access to testing, then they recommend that you separate yourself for at least 10 days. And as long as you've had no symptoms within that 10-day period, then you can come out of your self-isolation. And certainly, if you do have a positive test for COVID-19 and you're at home getting over, trying to recover from the illness, you should certainly seek additional medical care if you end up having trouble breathing, persistent pain, or pressure in your chest. If there's confusion, inability to stay awake or be alert, and if the lips or face or fingers start turning a bluish color, that means you're not getting enough oxygen to different parts of your body. So certainly if you have a positive test and you're recovering at home, do seek additional medical care if any of these symptoms arise. Now exiting. If you have a COVID test and you test negative, that means you were probably not infected at the time that your sample was taken. Now, a negative test could mean that your sample was collected too early in infection. Remember, we talked about the incubation period of the virus is on average 5 days. So if you're potentially exposed, you get infected with the virus on day 1 and maybe even on day 2, you may not be shedding enough virus for the testing to be able to pick up. That doesn't mean you're not infected. And it could be that you certainly, if you have a negative test, you certainly could be infected at a later time. So just having one negative test does not mean that you may not be exposed at some point in the future, and you would likely need to be retested again. So how to test is very important as well. As everyone is aware, COPAN is one of the leaders in collection devices for respiratory tract diseases. The gold standard set by the CDC and the FDA for obtaining specimens for respiratory viruses and COVID is the nasopharyngeal swab, or the NP swab. And on the right-hand side, you can see a pictorial of that swab. It's a very long swab, and COPAN is the leading manufacturer of these swabs worldwide. And you have the patient tilt their head back, and then it's a rather long swab, and you insert it through the nasal passage all the way to the back of the throat. There is no way that this swab can tickle your brain. It can't even come close to your brain, so don't worry about that. But it is inserted until it gets into the back of the throat, where the viruses will be concentrated so that appropriate specimen can be collected. And on this slide, and I will send out this slide deck for anyone that's interested in it, there's a very nice short video if you want to look at how a specimen is actually collected, a nasopharyngeal swab is actually collected. Now, after the nasopharyngeal swab, there's been a lot of other swab collections that have been used to test for COVID-19. One is simply a throat swab. Another is a nose swab, either a mid-turbinate nose swab or just an anterior nares, which is just right on the inside of your nostrils. And saliva, collection of saliva and gargle washes are also becoming popular specimens to collect from patients to submit for SARS-CoV-2 testing. Now, I do want to say a little bit about vaccination. We've all been seeing and reading an awful lot about vaccinations on TV and the news lately on in social media. So who should get a vaccine? Well, the CDC came out with recommendations earlier this year for how to phase in vaccinations and who should get vaccinated. And based on their recommendations, they came out initially with 3 different phases. They recommended that in the first phase of vaccinations in the US, that healthcare workers should be vaccinated, as well as people that are living in nursing homes and other long-term care facilities and the people that work in those facilities. After this, the CDC recommends the phase 1B should be essential workers, school staff, police, grocery workers, bus drivers, etc. And after this, they recommend phase 1C would be adults over 65 or any adult who has one of these high-risk medical conditions that puts them at risk for developing severe disease. Now, again, CDC makes these recommendations, and the federal government, as you know, is working to make more and more vaccines available to ramp up vaccine production for the population. But it is up to the states and the local jurisdictions to make the final decisions about their vaccination priorities. For example, in Union County, Georgia, where I live, right now, our county is giving vaccinations out to healthcare workers, people who reside in long-term care facilities and their staff, and also to adults over 65 and older, and to their care providers if they have a live-in care provider as well. And again, it will differ by state, and it may differ by county, and it may differ by public health jurisdiction. And there's also a link on here for San Diego County to see what who they are currently allowing recommendations for. And again, we hope that this will come and involve more and more of the population as we get more and more vaccines available in the United States. And we know that there are some SARS-CoV-2 variants out there, which gives us a little bit of pause as far as detecting these variants and mutants, as well as how well our vaccines will work on these variants. And you should understand that viruses, it's just their nature. A majority of viruses just constantly change and go through mutations as they grow and multiply and divide. Every time they grow, multiply, and divide, they can undergo these small changes or mutations or variations. So we would expect to get some of these new variants to emerge and then disappear. Some of the changes or mutations that happen in these viruses make them no longer fit, which means that they can no longer sustain an infection in a person, or maybe they can no longer be transmitted from person to person. So a lot of these new variants that emerge actually will disappear. However, there are other variants that will emerge and persist. And that's what we're dealing with when we talk about some of the variants around the world. And this is the latest information from the CDC that I have on the slide for you. Currently, there are 3 variants, and I got this information this morning, so it should be very current. There's 3 variants currently known to be transmitting around the country. One variant comes from the United Kingdom, it's B117. And for the viruses that have been genetically sequenced, so we know if they're the everyday routine, if you will, SARS-CoV-2, or if they're one of these variants, there has been 690 of the UK variant reported in the United States out of 33 different states reporting this variant. From the South African variant, which is the B1351, there's been 6 reported cases in the United States from 3 states. And then the P1 variant from Brazil, There's been 3 reported cases also in the United States from 2 different states. If you look at the graph below, you can see that as far as variants go, by far and away, Florida is leading the charge in variants. They have more variants detected to date in Florida than anywhere else. California, you guys are not far behind, somewhere between 100 to 150 cases of variants reported to date. And again, the light green are the rest of the states that have had at least 250 cases reported. So again, this is the latest information on the variants. One thing to understand is that not all cases undergo this genetic sequencing testing. So these are the ones that have undergone that. Then we know whether they're a variant or whether the initial SARS-CoV-2 virus that we had in the United States. So again, as more and more of the sequence testing is done on these viruses, these numbers will most certainly increase. Now, what about these variants? It is believed that these variants may actually spread more easily and more quickly. That probably means, remember when we talked about the R0 of the SARS-CoV-2 virus, the initial one, that it had an R0 of 2 to 2.5. These viruses, some of these variants, they believe that the R0 is even higher than that. So more easily and potentially more quickly spread. This certainly can lead to more COVID-19 disease. There's a lot of investigation undergoing currently with these variants to see whether they actually cause more severe disease. There are some reports out of Europe saying that they do believe that the B117 does cause more severe disease, but as far as I know, that hasn't been substantiated yet. But it certainly will lead to an increase the more and more we see these variants in the United States. If people aren't practicing appropriate mitigation measures, it certainly is going to lead to an increase in the number of cases. It'll put more strain on our health care resources than we already have. More cases will invariably lead to more hospitalizations, and more hospitalizations will lead to potentially more deaths. So even if these variants don't actually cause more severe disease on their own, just increasing their number, we know, will lead to more hospitalizations and potentially more deaths. But again, all of this is under current investigation. And they're also looking at the vaccines and these variants to see if they're effective or less than effective against some of these variants. So again, while we know there's a need to increase vaccination, we have to, some of us are waiting, and while the rest of the country and the rest of the world is waiting for vaccination, it's important to continue to do our physical distancing, wear our masks, wash our hands, isolate, and quarantine. This is essential right now to limit the spread. The more that we can limit the spread of the disease, whether it's the initial virus or one of these variants, the better off we're going to be able to protect each other and protect the public health. Now, there's a really good question and answer. This was, I think, about a week old now. It was in the New York Times. The link is here on the slide for you. A lot of good questions, a lot of good answers in there. I went through all of them, so this can give you some more information if you have questions about the coronavirus and SARS-CoV-2. I want to mention one other thing before we close, is that one thing to remember with the viruses, when you're hearing things about how effective, the vaccines, when you're hearing information about how effective the vaccines are, it's important to pay attention to what is said and what is written about not only the ability of the vaccines to limit mild illness, but also the ability of the vaccine to limit severe disease as well. Oftentimes, we know that we have 2 vaccines currently authorized for emergency use by the FDA. That is the Moderna vaccine and the Pfizer vaccine? I'm forgetting. But anyway, we have 2 that are currently out there, the Moderna and the Pfizer, I believe. So those 2 vaccines, even though, and they have a very high efficacy rate of 94 to 95% for presenting mild or moderate illness, but they have almost a 99 to 100% effectiveness of preventing severe illness. So keep in mind when the new vaccines come out, the J&J vaccine is being reviewed by the FDA now. So hopefully we'll have a 3rd vaccine in our armamentarium against this virus. Initial reports, we'll find out more when the FDA reviews and has their public review of the vaccine. But initial reports are that in the United States, with what we're seeing, the variants and the viruses we see in the United States, that the J&J vaccine will be somewhere around 72 to 78% effective against mild to moderate disease. But again, in the mid to high 80s in its effectiveness against severe illness. So those are things to keep in mind when you read and hear and watch what's going on with the vaccines. And again, the variants will come into play with this as well. So with that, I will stop. And Gabby, I don't know if you want to have some questions. I have some time. If anybody has some questions, we can do a little bit of that. But thank everybody for coming today. Really appreciate your attendance, and hopefully gave you some useful information about COVID and SARS-CoV-2.
Thank you so much for doing this. I'm gonna hold off and let anyone ask any questions they may have.
Hi, this is Heather. Can I ask a question? This is
Sure.
Heather Lavery. Hi, Susan. So when you talk about the vaccines too, I know there's a lot of chatter about the side effects or the risks associated with them. What would be your answers to some of those questions?
Yeah, I mean, some of the side effects associated with the vaccine are, some of the symptoms that you might get if you would have mild disease. Your arms, you're gonna have a little bit of a sore arm. Usually people have a little bit of sore arm after the shot. You may have a little fever, chills, headache, etc. That's a good thing because the vaccine is working. Right? So usually younger people may have a little bit more of those side effects. Keep in mind that the signs and symptoms that we have that are associated with influenza and even SARS-CoV-2 are mainly a response of your immune response to that virus. It's your immune response that causes the fever. It's your immune response that causes the chills. So that just means that your immune response is reacting to the virus, so that's a good thing. So yeah, you may have some mild signs and symptoms, but you are going to be protected against moderate and severe disease. So I am still waiting to get scheduled for a vaccine. I will tell you that I will be the first in line as soon as they call my name. I'll be down there when it opens to start getting my vaccine. I can't wait to get my vaccine and try to get back to a little bit more of a normal life. Yeah. So yeah, you may have some side effects associated with it, but to me, it is certainly better to have those few side effects than to risk severe disease from this virus.
And what about the question with people who've had COVID? Because I know people, my mom had it and her doctor said not to get the vaccine it said 3 months. What is the reasoning for that?
The reason for that is because we don't know yet how long the immune response lasts from having a natural infection or even really from having the vaccination. So until, we're learning a lot about this virus as time goes on. Remember, this virus had never been seen before on the face of the earth. So we're all learning about this as we go along. But we don't know how long immunity may last from a natural infection or even from vaccination. People are speculating. We don't know yet. We could, COVID could be something we have to have an annual booster for, an annual shot for, like we do for influenza. It could be that we only have to have a booster every few years. We just don't know yet, but that's the reason they're recommending. They know natural immunity will have your antibody response and your other immune responses engaged for at least 3 to 4 months. But after that point, there's just no data out there on how long that immunity will keep you protected. So that's why they're asking for people to, if they've already had a documented infection, to wait at least 3 to 4 months before they get their vaccine. They should be protected during that time, but then they should get a vaccine after that point. Okay. And that may change in the future as we learn more and more about this vaccine and we learn more and more about the immunity after a natural infection.
Okay. So it's kind of similar to, not to usurp all the, I was just interested with when you're getting a flu shot, but with the flu shot, if you have active symptoms, then they tell you not to get the flu shot. But with COVID, it's if you've had a positive test.
Right.
Okay.
Yeah.
Okay.
Again, because you should have some natural immunity going on for a while. With influenza, we know that's going to last throughout the influenza season, but with COVID, we just don't quite know yet.
Okay. Okay. Thank you.
Sure.
Okay, there's no other questions. Thank you, Sue, so much.
Sure.
I'm sorry, I have a couple of questions. This is Brian Hill.
Hi, Brian.
Hi, Dr. Sharp. This is a great presentation, by the way. I learned a lot. I have a few questions, and if I may, I'll ask them if we have time. But my first question is a statement followed by a question. I think there's a misconception that getting tested right after potential contact with someone that's infected is adequate. And from what we know about incubation periods, we know that that's not quite the case. I know that CDC has recommended that there's a range of incubation period for SARS-CoV-2, but is there an optimum delay from when you're potentially come in contact with an infected person to when you should get tested, so that it doesn't cause a false negative?
Yeah, that's a really good question. And again, I believe the recommendation, certainly if you get signs and symptoms anytime before, but I believe the recommendations is once you've been exposed to someone, because you're right, once you're initially exposed, you're probably, even if the virus is starting to set up shop and start an infection in you, you're not going to get a viral load that's going to be able to be detected by the testing systems that we have now for a couple of days. So you're right, getting tested, the next day after you were exposed to someone the day before could give you a false negative result. So the CDC probably has recommendations on that. I could look that up and add it to the presentation when we put it out, but just based on, like you said, what we know the incubation period, I would say I would wait a minimum of 3 days. At day 3 and 4, we know you can start shedding the virus even before you get symptoms. So I would say an average of about 3 days after an exposure would be an optimal time based on that average of a 5-day incubation period to get tested. But I will check with the CDC to see what they're actually recommending, and then I'll add it to the presentation before I send it in to be posted.
Okay, thank you very much for that answer. I have one more question, if I may. Do you have any recommendations to look at data that reflect sensitivities for antigenic rapid testing versus PCR testing, and really for those people that may have potentially been infected early on when all of this started? How efficient were those? How efficient was the testing? And do you have a comment on what's the preferred standard?
Yeah, it's really interesting. So let me tell you a little bit about the differences between a PCR and an antigen test. A PCR are much more sensitive, so they're going to pick up smaller amounts of viruses as compared to the antigen tests. So for example, in that first couple of days when you first get infected, but you may not be shedding enough virus, the PCR is going to pick that up. If you do you do day 1, day 2, day 3, 4, and 5 until someone gets symptoms, the PCR will detect the viruses there before the antigen tests do. So that just means that the PCR is more sensitive to the antigens. Now, when you're in the disease symptoms, so if someone's having signs and symptoms of disease, they both work very well. The antigen tests work very well for the most part, generally speaking, when someone is actually having signs and symptoms of disease, because they're shedding a large amount of virus at that time, and the rapid antigen tests are good enough to pick up those high load of viruses. Now, what we don't know exactly what happens is on the back end. We do know that PCR can stay positive for a number of days or even potentially weeks after a person has recovered and has no longer has any signs or symptoms of disease. That's because some of the remnant nucleic acid from the virus can still be around, and that's what's detected by the PCR. We believe that the antigen tests, once a person recovers, will probably go to negative before the PCR tests go to negative. But when you're talking about initially getting the infection, yes, the PCR is more sensitive for picking up early infection and even asymptomatic infection than are the antigen tests. But once people start getting signs and symptoms of disease, the antigen tests, for the most part, work very well, as well as the PCRs do.
Okay. Thank you so much.
Mm-hmm. Sure.
Dr. Sharp, my name is Russell. Could you explain to me what an equivocal test is and how that relates to infection or non-infection?
Yes, it kind of equivocal or indeterminate kind of depends on what assay is being performed. When we talk about PCR assays, Some of these assays, a majority of them will test for a couple of different targets from the virus. They'll target a couple of different nucleic acids and that are specific for the virus. If one of those target is positive and the other one is negative, it may be called indeterminate or equivocal. So that's one way you can get an indeterminate or an equivocal, because most laboratories, well, depending on the laboratory, they may or may not call a test positive if only one of the targets is detected and the other target is not detected. So that's one way to get it. There's some assays that only use one target, and if that target is between a certain, this is kind of hard to explain, but if it's potentially there, but it's not there in large enough numbers to be sure that it's actually detecting the virus and not having something else interfere with that very weak result, they could call it indeterminate or inconclusive as well. So a couple different ways that you can do that. Another thing that can be called indeterminate with the PCR tests, they also test for a gene that all humans have. Basically, that's to basically say that you got a good collection. You don't want someone just taking a swab, and waving it around in the air and then sending it in to be tested. You want to make sure that you have some human nucleic acid on that DNA on that specimen as well. So most of the PCR assays will also test for that human gene. If that human gene is not detected, then it will also send out an indeterminate or equivocal type of answer. So there's lots of different ways you can get that kind of an answer. Most laboratories, if they get an indeterminate or equivocal or an invalid, they will repeat the sample one more time to see if they can get a clear positive or a clear negative. An alternative to doing that, or if they get the same result, is to recollect the patient and test again.
Thank you.
Mm-hmm. Okay, well, thank you, everyone. I really appreciate everybody coming today. If you have any other questions, you guys know how to reach me on email. I'm happy to have further discussion or answer any emails that you have with questions on them. But again, I will send out the presentation, and on that last slide of the presentation, it will have that Q&A, the link for the Q&A that you can go to that also has a lot of really good information on it as well. So thanks, everybody.
Thank you so much, Sue.
Sure, my pleasure. Bye.
Thank you.
Thank you.
Everybody take care. Wear your masks.